Welcome to our talk, Pain Hurts. My name's Matt. I work at the health center. My colleague Colleen put this together, but she's not able to make it today, so I'm pinch hitting. The funding for this talk came from the Community Response Network. There's some information at the table here if you don't already know what that is. It's a network of concerned friends and neighbors who keep an eye out for seniors who are at risk of abuse, neglect, or self-neglect, and pitch in to help alleviate those situations. So we have three speakers today. We have Shirvin Lee from Pain BC. We have Sandy Logan from the Bowen Wellness Center, Physiotherapist, and we have Dr. Brenda Lau from changepain.ca. So first up is Shirvin. Shirvin Lee is a registered clinical counselor with Pain BC. She supports many of the programs there. She's passionate about normalizing mental health, particularly with a cultural lens. Her focus is on meeting people where they're at and supporting them at a pace that works for them. So please welcome Shirvin.
I'm Shirvin, and I'm a registered clinical counselor. I've been with Pain BC for a few years now. So any questions you have about mental health in particular, feel free to ask. But today, we do have a lot of different brochures and pamphlets here with our programs. So anything you forget, it's all here as well. And we have opportunities for questions at the end too. Today I'm going to talk a little bit about what pain is and Pain BC resources, and there are also a couple of videos I wanted to share. So let's see if this clicker works. Oh, there it is. So to start, I'd like to just acknowledge that the Pain BC office and myself, we are on the traditional, unceded, and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and happy to be here on the house sound today. Yeah. Personally, just from Burnaby. So a couple of quick disclosures. I am an employee of Pain BC, and many of our programs are funded by the government of British Columbia. So about Pain BC, what's the most important thing here is our vision, where we want to make sure there's a future where no one is alone with pain. And we have a couple of different ways to support people with that. And today our main focus is going to be on education. So pain education, some more things about nervous system regulation, and about our resources. I'm going to start off with identifying acute versus chronic pain, going into some of that pain science and about the impacts of living with chronic pain. Then I'm going to go into the nervous system and at the end about our Pain BC resources. So right away, I know the pictures might be a bit hard to see, but when you look at the different individuals here, you might not think that they live with pain. And one of our volunteers gave me this example that I found to be really impactful. You know, not to dismiss or invalidate cancer, but the example was if you imagine two people doing a marathon run. One person might be living with arthritis and fibromyalgia, and then the other person has cancer. You might hear people say about the first runner, oh, you know, they don't look that bad. Their arthritis might be fine that they can do this half marathon. It's fine, they're fine. And then with the cancer patient, you might think, wow, how strong is that person that they can do this run? But what happens is you end up invalidating what someone's going through just so because you can't see it. You know, you might have actually more sympathy for someone who has a broken arm and they're in a cast versus someone who's going through severe back pain, but you can't see that right away. So when you look at these pictures or you think about yourself or someone living with pain, that's why our vision is we don't want anyone to be feeling alone with their pain, especially because it can be so invisible. So what is chronic pain? The actual definition of chronic pain is that it's an unpleasant sensory and emotional experience. And I really wanted to highlight this because a lot of the times we will focus on the first half, the physical half. It's unpleasant, it's a sensory thing, but maybe I'm biased because I'm a counselor, but I think the emotional experience is also really important. And if you're not familiar, chronic pain usually occurs if there's 3 months of continued pain and it's persistent. And it's actually its own diagnosis. And in Canada, 1 in 5 people live with chronic pain. This was taken in 2021. I feel like this number has probably gone up because of the pandemic, and people are now experiencing long COVID, and more research is coming out about that. It's also the #1 driver of disability in Canada. So, to change things up, I do have this video about the mysterious science of pain. And this one's a few minutes, and it's a good way to learn a bit more with visuals.
In 1995, the British Medical Journal published an astonishing report about a 29-year-old builder. He accidentally jumped onto a 15-centimeter nail, which pierced straight through his steel-toed boot. He was in such agonizing pain that even the smallest movement was unbearable. But when the doctors took off his boot, they faced a surprising sight. The nail had never touched his foot at all. For hundreds of years, scientists thought that pain was a direct response to damage. By that logic, the more severe an injury is, the more pain it should cause. But as we've learned more about the science of pain, we've discovered that pain and tissue damage don't always go hand in hand, even when the body's threat signaling mechanisms are fully functioning. We're capable of experiencing severe pain out of proportion to an actual injury, and even pain without any injury, like the builder, or the well-documented cases of male partners of pregnant women experiencing pain during the pregnancy or labor. What's going on here? There are actually 2 phenomena at play: the experience of pain and a biological process called nociception. Nociception is part of the nervous system's protective response to harmful or potentially harmful stimuli. Sensors in specialized nerve endings detect mechanical, thermal, and chemical threats. If enough sensors are activated, electrical signals shoot up the nerve to the spine and onto the brain. The brain weighs the importance of these signals and produces pain if it decides the body needs protection. Typically, pain helps the body avoid further injury or damage, but there are a whole set of factors besides nociception that can influence the experience of pain and make pain less useful. First, there are biological factors that amplify nociceptive signals to the brain. If nerve fibers are activated repeatedly, the brain may decide they need to be more sensitive to adequately protect the body from threats. More stress sensors can be added to nerve fibers until they become so sensitive that even light touches to the skin spark intense electrical signals. In other cases, nerves adapt to send signals more efficiently, amplifying the message. These forms of amplification are most common in people experiencing chronic pain, which is defined as pain lasting more than 3 months. When the nervous system is nudged into an ongoing state of high alert, pain can outlast physical injury. This creates a vicious cycle in which the longer pain persists, the more difficult it becomes to reverse. Psychological factors clearly play a role in pain too, potentially by influencing nociception and by influencing the brain directly. A person's emotional state, memories, beliefs about pain, and expectations about treatment can all influence how much pain they experience. In one study, children who reported believing that they had no control over pain actually experienced more intense pain than those who believed they had some control. Features of the environment matter too. In one experiment, volunteers with a cold rod placed on the back of their hand reported feeling more pain when they were shown a red light than a blue one, even though the rod was the same temperature each time. Finally, social factors like the availability of family support can affect perception of pain. All of this means that a multi-pronged approach to pain treatment that includes pain specialists, physical therapists, clinical psychologists, nurses, and other healthcare professionals is often most effective. We're only beginning to uncover the mechanisms behind the experience of pain, but there are some promising areas of research. Until recently, we thought the glial cells surrounding neurons were just support structures, but now we know they have a huge role in influencing nociception. Studies have shown that disabling certain brain circuits in the amygdala can eliminate pain in rats, and genetic testing in people with rare disorders that prevent them from feeling pain have pinpointed several other possible targets for drugs and perhaps eventually gene therapy. Ever wonder how pain relievers work or how other animals experience pain? Check out these lessons to learn more.
Okay, that's a little bit on the mysterious science of pain, but I really like this image here of the alarm because I feel like when it comes to pain, it's our bodies, this alarm, almost like a fire alarm, telling us that there's some kind of danger. You know, we're all born with the natural instinct to escape danger, but the question is, how do you escape it when it's happening inside of you? You know, with fibromyalgia, with a medical condition, you can't just jump out of your body. So it's a interesting question here. You know, what is that purpose of pain? When you touch that hot stove, you can remove your hand from it. When you step on a broken glass bottle, you can move your foot and take the glass out. But we can't do that when the pain is inside. And that's very confusing because your internal fire alarm or this harm alarm is going off. So what I'm hoping to teach everyone today is how can we turn down that alarm so it's not just blaring and loud and overwhelming, but it feels a lot more manageable. We feel like we can have control over it. And I know that there's going to be more information on pain science later, but today I wanted to share some of the highlights, and that's that pain is all processed in your brain and your spinal cord, regardless of where you might feel pain. So some of you might have heard of, let's say, phantom pain, where someone, let's say, had their right leg amputated, but they might still feel the pain in that leg, even if they don't have the leg anymore. And the reason is because all the pain is processed in your brain. So even if you don't have that body part, you're still going to feel it. Sometimes you might hear people say, well, it's all in your head, which is one of the most dismissive things you can hear. There's some truth to it on the scientific level where it is processed in your head, in your brain. And that's why it's important to learn how to turn down that volume, even if it's just a smidge, so you feel like you have more control in your day-to-day. And this one, I know it's going to be hard to read, so I'll read it out loud here. But it looks so busy for a reason, because this is how it feels to live with pain. It can be so complex. Over there it might say, I miss my friends. I don't have the energy or time to see them anymore. I have so many doctor's appointments. Maybe it's, I want my life back. I can't even walk my dog around the block. Maybe it's, it hurts too much to do anything. We're feeling really defeated. I must be crazy. Why am I doing this to myself? And it can really feel so complex living with pain. So I like to break things up with this biopsychosocial approach. Just like the definition of pain, we focus a lot on those physical sensations, the biological pieces. So your physical health, genetics, how it shows up in your body. But there's also the psychological, and then the social, cultural, and spiritual pieces. How does it impact you as a person? How does it impact your relationships, your beliefs, culturally? Those are all important aspects when it comes to thinking about pain and about our lives. And this is in the context of chronic pain. Some biological changes could be maybe the flare-ups or decreased mobility. Maybe you have difficulty sleeping. You can't sleep for more than 2-3 hours at a time. Psychologically, it could be feeling anxious, wondering what the doctor's going to tell you, how you feel about yourself has changed. Socially, maybe loss of income, loss of your home. It could be loss of interest in activities. So much is going on beyond the physical aspect. And over here you'll see that many of us might feel like we're in this pain-centered life where we feel isolated, there's that fear of what's going on, the pain continues, you feel like nothing can be done, and then your activity is reduced. And that's when pain becomes that center. That fire alarm keeps going off and it's so loud and unbearable. And we're gonna see another image of this, but in a different way, and that's in the approaches to care. So you'll see here, how can we get to that more balanced life? It's, maybe the pain doesn't 100% go away, but we can chip at it. We can really reduce the volume of pain. How can we increase our social functioning or feel more motivated or inspired to do more activities? That's why I like to go into the nervous system. So you might have heard about the fight or flight response before. That's going to be like that fire alarm, that harm alarm that's going off. And remember, so your pain is all processed in your brain. And what else is processed in your brain? Your emotions, how you feel. So all of that is connected, regardless of where you feel your pain. And your nervous system is activated whenever you're going through any type of sensation. And I have another image of this that might be easier for us to understand later on. But I'm going to, before I put this all together, what's also important for me is to talk about trauma-informed care. Maybe you've heard of the term, maybe you haven't, but I feel like whenever we maybe get some support or we're telling someone we're going through something, people might ask us, well, what's wrong with you? What is the problem here today? But the question I like to ask is, what happened to you? What is going on? What is the picture that we can all try to understand so that you can get the best care you deserve? And I like to do this through a few pillars that might be important for you to keep in mind when you meet with your healthcare professionals or the way you talk to your loved ones about your pain or about their pain. It's building that safety. It's not judging people just because they look like they're okay, but what if they're going through something that you have no idea about? It's building that trust, making it so that people know that we're all humans, we're all going through something, and collaborating, finding other professionals or other friends or families to work on things with so that you don't have to do it alone. And another piece of trauma-informed care is awareness. Different cultures, different values and beliefs. So these are all really important when it comes to understanding care and how we can care for ourselves and be able to talk to healthcare professionals. So now I'm switching back into that nervous system, right? You might have heard about the fight or flight, but today I want to also introduce freeze and fawn. When we think about trauma, it's not just one event or one thing or accident that might have happened, but it can be ongoing. When you think about the news and someone's been in an accident, we really feel for them in that moment about the accident, but we always forget about what about the next year of recovery or healing. What is that person going through? How does that trauma show up in your nervous system, in your mental health? So some of the responses that we might see, the fight, maybe someone's more irritable, easier to feel angry. Maybe you notice it when your heart rate keeps going up, you're getting nervous about things. Flight might look like increased panic or anxiety, or you're always worried about what's happening next. Do you have all of your medication, all of your appointments lined up? You want to make sure you don't miss a call. But there's also freeze, deer in headlights, feeling really stuck, like you're shutting down, like you feel like you can't do anything anymore. And then fawn, people-pleasing tendencies, wanting to say yes to everything. If I say no, maybe they won't ask me anymore. Maybe people will forget about me. Difficulty setting boundaries. So to put it all together, our whole body, our whole system, it's going through different things when we experience pain, when we feel isolated, and it shows up in ways that we might not have had a name for. So it's helpful to understand all these things. And I like to understand it through the window of tolerance. Okay. And this is a visual where I actually have another picture I'm going to go to that might be easier to understand. So imagine that you're on this very cute unicorn floating down this river, right? When it gets really narrow here, the water is faster, you don't have a lot of space to navigate and go through, and you feel like you're going to hit all these rocks, and it feels really unsafe. And that's when your window of tolerance shrinks. When your nervous system is going in overdrive, when you feel like you don't have control, when it feels dangerous. That harm alarm, the fire alarm, it's going off. But then, here on this right side, it's wider. You have more space to travel, it feels calmer, you can just go at the pace you want. That's when your window of tolerance expands. So, I'm going to go backwards a little bit here. When you're noticing yourself having these responses, fight, flight, freeze, fawn, this is a chance to think about what is shrinking my window of tolerance. What's making me stressed out? Is it the people around me? Is it trying to make sure I'm on top of all my appointments and medications? What's shrinking it? So how do we turn down that volume? This is when we really consider what expands that window of tolerance. What can help us feel like we're more in control, turning down that volume? For me, sometimes it's washing my face, drinking water, things that feel manageable and doable. Something for everyone to think about. What expands your window of tolerance? This is my other video here to really put it all together. This one's a couple of minutes. Okay.
This is me. I could say that, this bit is me as a mum and this bit's me as a teacher, but either way, here I am. And I'm actually really attached to me and very invested in me, and we've been together for quite a while. And this is pain. And first it comes like this, doing. I don't like that. I really don't like that. So I take it to a doctor or a nurse and I say, please, can you take away my pain? And they go, yeah, sure. There we go. Hang on, a little bit more. Or better now. Good as new. Yep, there's me. But the pain comes back sometimes. Lots of it. Dollops of it. And it starts affecting all of me, because look, this is life happening. And after a while the pain affects my work and me as a mum, and me as a teacher, whatever. Here it is happening. Now this is me. I'm not as bright as I used to be. I can hardly recognize myself. I'm really not liking this. So I take it to the doctor and I say, please, can you take the pain away? And the doctor says, I can't. Now this is me, not right, not happy. And I think, what can I do? And I think, I'll add more to my life. Bits that have nothing to do with the pain, like all the things I do with the people I love, and things I love doing. I'm going to really invest. I'm going to add dollops of the bits of me that aren't anything to do with the pain, and here is life happening. Now this is me. I'm not as bright as I used to be, and I'll probably never be as bright. But I'm brighter, and look, I'm bigger.
So I really like this video because it reminds us that we can do things to expand our window of tolerance, to take care of ourselves, to turn down that volume of pain. So for my last little bit here, I'm going to go through some of Pain BC's resources and a reminder that we do have our brochures and things here that you can take home with you. So this one is not too relevant for everyone here unless you're a healthcare professional, but what we're trying to do is we notice there's a gap in the education for healthcare professionals about chronic pain. So we are really working hard to educate as many health providers as we can to teach them more about pain, its impacts, and how to treat people with pain. So that's one of the things we're doing. And this one, the pain support line, you can call or text the number, and it's all online and with the pamphlets here, but I like to really describe the pain support line as a Google for chronic pain. So if there's a resource you're thinking about or wanting to look into but don't know where to start, you can give us a call. Right? We want to take away that burden of research so you don't have to do all of it yourself, or even if it's for a loved one. It's another place to just talk to someone about your pain, and myself and our team of other social workers and counselors take care of the line, and we answer Monday to Friday. And people contact the pain support line for a lot of different reasons. Some of the most common needs, usually finding a pain clinic or specialist. Good thing Brenda's here today to talk about the pain clinics. Pain education, emotional support, finding a doctor or support groups. So a Google for chronic pain. We also have something called Coaching for Health, where it's a one-on-one program with one of our volunteer coaches, and everything here is virtual, so over the phone or video, and it's free, and it's for up to 12 sessions or 12 weeks to work on any pain-related goals. So either your healthcare provider can refer you, or you can do it through the pain support line. You can give us a call. We also have pain support and wellness groups, where we run these all on Zoom. It's bi-weekly, and it's a way to connect with others who are also living with pain, and it's peer-led. So we have different topics that we go through, different regions, and different age groups too. Another program we have is Making Sense of Pain. It's a 9-week program about different topics about pain, also done virtually. And these are more closed groups, whereas the other one is a drop-in style. This is something you register for. It's 9 weeks. You learn about different topics, and then we go through them together. So some of the topics, it's the biopsychosocial model of pain, stress management, grief and loss, self-talk, self-compassion, and it's for 9 weeks. And you can register online as well. We also have Live Plan B Plus. This is an online, more educational, interactive tool. If you like to just be more hands-on, maybe look through different articles and different things on your own pace, Live Plan B Plus is one of them. And if you want to hear me talk more, there's something called Empowered Relief, where I do this in partnership with Pain Canada, and we run this once a month. It's a 2-hour, one visit only type of more pain science webinar, where we go through the pain science and some more practical skills about managing pain. So that's called Empowered Relief. The one in March is for youth, so the next adult one will be in April. And again, everything you can find online. We also have resources in different languages, and they're all translated, and we have these information sheets that you can find online with different topics, and it has a lot of resources that myself and the team of social workers have put together. And down there is the link. So the Find Help page at Pain BC is where you can find everything, but you can always let me know if you have questions or take one of the pamphlets home. Okay. And one of the last things I wanted to do today was just introduce some simple, easy to do grounding exercises that you don't have to go buy and get something or sign up for a program for. If you're really noticing that window of tolerance shrinking, these are ways you can expand it. So one of the things that I like to have, which actually fell off my wrist, I think it's in my jacket or somewhere, is having some type of anchor. I usually have a scrunchie that I like to kind of pull at, but luckily Brenda gave me this clicker that it's been nice to hold on to. Otherwise, I don't know what I'm going to be doing with my hands the whole time. I'd probably be like this, playing with my fingers, but having something to hold is a really nice way to ground and anchor ourselves. But I can't guarantee that this won't be sweaty when I hand it to you. Another thing I like to do is walk slowly and noticing. A lot of us move and do that so automatically, like the way we breathe, but sometimes it's just even like left, right, left, and doing it one motion at a time. I feel like that just slows everything down when you pay attention to those movements. 5, 4, 3, 2, 1 is a very popular grounding exercise, and I'll do it right now with everyone. So it's telling yourself, what are 5 things you can see? I definitely see this light coming at me, that's one thing. The microphone, I see the laptop, I see this kind of tape on the ground, I see that rope. 5 things I can see. 4 things I can touch, this clicker, my sweater, my phone in my back pocket, this couch. 4 things I can touch. 3 things I can hear. My knees are clicking. I hear that every time I move. I hear some of the laughter, some of the talk. I hear this, the PowerPoint thing going off. And it gets a bit harder here. 2 things I can smell. I can smell the coffee I had, which is also the one thing I can taste, the coffee that I had. What else can I smell? I smell my laundry detergent. It's really paying attention and slowing down so that we don't feel like we're in overdrive. We don't feel like everything is shrinking, but we just pay attention to what's around us and let that expand. Another one is called balloon breathing, if you want to try that. If you imagine a balloon inflating and deflating in your belly, it might help you put your hand on your belly so you can feel that inflating and deflating. That's one thing. And then the last thing, if you like to do, is a butterfly hug. It's just crossing your arms and tapping slowly. And the key is not to tap like this, and everything just goes really fast, and that defeats the purpose of it. It's really just slowing down, really soothing ourselves. So these are some grounding activities that can help expand that window of tolerance. And that is it from me. Thank you, everyone.
So next up, we have Dr. Brenda Lau. Dr. Lau is a pain specialist and anesthesiologist with over 20 years of experience in both. She has a master's of medicine in interventional pain management and is acknowledged as one of the founders of the subspecialty of pain medicine in Canada. Brenda was a co-founder of Pain BC in 2004, and she has also been involved in the Providence Healthcare Race Pain Hotline, co-chaired the Pain Practice Support Program, helped create the BC Women's Hospital Chronic Pelvic Pain Program, and has been the medical lead on regional pain initiatives around the province. In 2013, she co-founded ChangePain, a Vancouver-based pain center that provides multidisciplinary care for myofascial, spinal, neuropathic, pelvic, cranial, visceral, post-surgical, post-trauma, and post-cancer pain, as well as complex regional pain syndrome and pain stemming from chronic diseases. She has led numerous national and provincial and hospital-based initiatives to improve understanding of pain, improve pain treatments, and improve pain care training. She recently delivered a TEDx talk in Surrey, joining one of Canada's most respected TEDx stages. So, Brenda, please join us up here.
I just want to get a feel of just everyone here. Who, and it doesn't mean that you have it, but do you have an interest in joint pain. Anyone have an interest in joint pain? Okay, we've got a couple of hands, maybe a quarter. What about headache pain? Okay, about another quarter. How about back pain? That almost should be about 80% based on the population. Pelvic pain? Okay. And neuropathic pain. This is nerve of all types. Okay, very good. Abdominal, IBS, all types, okay. What about widespread pain? Okay, all right, now we're talking. So this is just background, my team. As a bit of a disclaimer, I am the founder and also the medical director of Change Pain Clinic. And we're one of many clinics that Shirvin has actually made reference to through Pain BC. And I'm excited to kind of give you a different approach to how you want to think about pain clinics. So let's test of the video. Interesting, Shirvin.
I didn't butcher it for you.
That's okay. Let's see how that works. That's okay. Let me see if I can just do it this way here. And if not, I'll just do it manually. Okay. So I'm just very honored to be able to share my work, not just here in Bowen Island, where we're on the unceded territories of the Musqueam, but also where our clinic is in Burnaby of the Tsleil-Waututh as well as the Squamish Nations. I'm just going to do it manually. That's okay. Maybe it's battery out. A few disclaimers. Most of my work is actually educational, policy, as well as curriculum development. I am an associate professor with the UBC, so we are aiming always to increase training opportunities, and we're so proud to see the 20 years work that Pain BC has done over the last 21 years now. So what I wanted to do is break this talk up in kind of 3 sections. And I hope that when you come away today, not only do you feel empowered, not only by what Shirvin's mentioned about the everyday slowing down of your system, but also what can we do with that nociceptive pain? Nociception is body, tissue, receptors, things that are changing, whether it's abdomen, the migraine headaches, or it's joint pain. But I break it up into 3 key levers first. Second, I want to go into what whole person care is, because how many of us in this system often sees a person and says, just tell me one symptom. How many? I hope that's 100% here, because that's the problem. You're not just one body part. You're a whole person. And we can't change and we can't treat pain in just one body system. And finally, what can we do with interventions? Because not everyone needs an actual needle. There are different types of interventions as well. Okay, let's just start with walking our talk. Shall we just do a stand-up right now? Because every 45 minutes to an hour, I hope that we actually do stand up. And that might only be a couple minutes. And if those of you who are available, if we could just raise up, just even arms up. Just this alone. Anyone who can do it, amazing, and you can sit down at your leisure. But that is just some study I'm going to bring up fairly shortly, because sitting more than 4 hours a day is one of the things that we want to not do. Okay, let me get into that. And I welcome you to stay standing if you want to, in fact, because now over these years, I rarely sit. Okay, and I'll get into that shortly. So I'm going to start off this talk very differently. About 3 weeks ago, I did a TEDx talk. Strength is freedom is my basic theme. I'm opening up this pain talk because I'm not going to go into interventions if I don't understand what's my outcome. Strength is freedom, not just mobility, power, or balance. We're talking about the mindset. Shirvin already touched a little bit based on that, because it's not just pushing through. It's literally saying, getting into our bodies, really understanding sensations, the connections, but it's also the freedom of looking at expanding that window of tolerance. So I bring this up because in my TED Talk, there were 3 critical questions, and there's a magnet here that helps remind you, if you'd like, those call to actions. The first one, did I interrupt my sitting time today? Second, did I safely challenge my muscles and bones? And that looks different for everyone. Did I eat in a way that builds those muscles and bones? And they seem quite simplistic, actually, these questions. But if you actually dig into and ask your neighbors, ask your friends, you'll be surprised how often we don't do this. And what's interesting right now, let me get into just a couple of the studies. They're not going to go in depth, but this is what's happening. This was a study of over 1 million people. And literally they took people who either exercised or didn't. And the recommended exercise, about 150 minutes a week, let's say, of all types. Did they find this out to be shocking for them? That even if you did meet the 150 minutes regularly per week, but you sat more than 4 hours a day, you undermined your exercise benefits. Okay? So I'm not saying that you lose all benefits. All movement is helpful. Even just that standing up we did right now. The little bits that you do every walking, every day of your dog, and every day that you try is all good. But what's happening right now is that when we sit, and let me show you an exaggerated sit. So I'm sitting right now, as we all are now. But what happens is that makes certain muscles tight. It trains them a certain way. So if we sit for too long, they stay in that memory. So even when I'm standing up, I'm actually literally still not in the same position. And I know Sandy, our physiotherapist here with our community center, was going to speak a little bit more around these things around movement. But that's the learnings from this, and that's why did I interrupt my sitting time today. Second study, multiple studies, super important one, especially for women. But men and women alike, when we hit 70, we equalize. Did you know? By 70, right now, our current day, 75% of women have osteoporosis. Did you know that by 70, 50% of men have osteoporosis? Not just a woman's disease. And so what we're talking about is an epidemic of weakness in muscle and bone. And they used to think that's just aging. Oh, you're just aging. That's not true. So there's some powerful studies out of Australia, the Bone Clinic, Melinda Beck, amazing studies with full osteoporotic patients. And I mean weak bones, right? Osteoporosis, weak bones. And I was one of them at the age of 47. I share you that story because I was shocked. And that is why we have to look at pain, recovery, performance very differently. So in this case here, they took osteoporotic women in this Lift More trial, but there was also a separate one for men, age 70 and above, that when they started them on a safe progressive loading, weight training, and the nutrition I'm about to talk about as well, we actually saw bone growth. When they thought this was not possible, when you finished puberty, when you finished being 30 years old, when growth hormone drops, and that's the key. After the age of 30, especially women, because in together with the drop of estrogen, it really affects women faster than men. Men, you start to see things like back pain, joint pains around the late 40s, around 50s. A lot more than women who often will feel it somewhere in the late 30s even, but get ignored, and then it really hits them at menopause. So that's a separate talk altogether, but this is an example. We can reverse this. Finally, am I eating enough to build those muscles and bones? Now, it's not just resting on protein, but we know as we age, more of us need more than we think we need. And so that changes from person to person. Like if you have kidney disease versus you're able to have stomach issues, restricting certain foods, we know that changes. But protein is super important. So can I just have people hold up a fist? Just everyone hold up a fist, okay? And this person's fist is bigger than mine. This person's fist is about similar, a little smaller. Your fists are proportional to you. Keep holding it up, please. This fist is a portion of food. And when you go to your store, this portion represents, let's say, if you eat meat, the size of meat that's about 20 grams of protein. Now, if you're vegan, this portion is about the same as well, maybe a little bit bigger you'll need to eat equivalently. How many grams of protein do you need, everyone? Does anybody know? And you can bring down your fists, of course, but you can keep them up if you want to. But how many grams do you think you need? Any number. Take a guess. 60 did I hear? Okay. Any other guess? 100, okay. So it's going to be proportional. This gentleman is more than this lady here because we're proportional. So it's about somewhere 0.8 grams to 1 gram per pound of body weight. So if you're 100 pounds, you're 100 grams. If you're 200 pounds, about 200 grams. And you're thinking, wow, what does that look like? So one fist means about 3 of those fists of food a day for the average person, men and women alike, because your fist is proportional to you. And if you're vegan, it's about 5 fists of that food. It's a lot. Before I measured my protein, I actually realized I didn't eat enough. Okay, so I'm going to go into this shortly because it's all about strength is freedom. So I'm going to leave this for the time being. I'm going to go into the sections really going to pain management. Because here's the problem. Patients walk in my room. Brenda, I can't walk. Brenda, I can't weight lift. I can't eat that amount of protein or food. All 3 questions and more people say to me. And that's why I say, let's look at the outcome. It might not be achieved right now, but let's move towards it. Because it's the mindset. If we understand where we're going, we now can look at the baby steps to progress there, and we must, despite pain. But that's where we come in. Because I know, just like this knee, that is meant to be surgical. This was a surgical knee, this right knee. And before I understood pain management in the way of strength as mobility, this was meant for surgery. And I'm showing that to you because I was shocked by both thin bones, bad bone on bone, osteoarthritis, back pain, big surgeries, removing 7-pound tumor. I mean, you name it. I've had cancer therapy, I still have cancer. So I'm sharing you these parts because I'm a patient too. And understanding that these are the barriers that we often think stop us. So it opened my eyes that for me to treat this pain, and for me to actually deal with this knee, I didn't need a needle. I needed to build my muscles. And I needed to eat to build those muscles. And it took me about 2 years, but it happened, and I was shocked. But to get there, we sometimes have to get a bit of help. This is a cartoon picture of your lumbar spine. So there's a vertebrae right in the back of that white area. The blue is representative. You don't look like that inside, but that's like fascia. So it's like a saran wrap that supports your muscles and skin and fat, and so it's everywhere. And then it's on the outside, there's your skin. So basically, as a pain specialist, when we are trained, even though I am as a background anesthesiologist, as Matt mentioned, the subspecialty, which is now a formal specialty in Canada, is a pain specialist understanding the layers of your body. But it's also where the targets of where our procedures can occur. But it's not enough to just look at a target. Remember I said it's not a body part. This is only just a very small representative of a piece of what Shirvin just talked about. It is in the brain. We process it in the brain. But our pain cannot be separated from what we eat, how we move, our mental health, the relationships we have. Because even here, when I see into your eyes, I hear and feel you. This oxytocin that we're secreting adds to the health of our brain. Just being with another person. And just doing that alone helps the nerve health, helps your brain health, helps pain. So we can't ever separate it, body, brain, or other parts. And we know wherever we can, earlier access is going to be better. That's why I cannot stand the fact that some wait lists are years before you see someone. Because that means that maybe we've been walking on it funny like I was. I was walking on my leg so funny that I lost 1/3 of my muscle on my right side. That's why I started keeping on right knee pain. So these kinds of things are just understandings, new understandings. Amazing, it works. So this is a little bit of what Shirvin was saying, Shirvin was talking about. We always have to think of pain as a whole person care. So when I now look at someone, I'm not looking at your back pain saying it's just your back, your facet joints or muscles. I look at you as a person at what your age is. I also look at you, what's your biological sex, not the gender, but what are you sensitive to? Estrogen, testosterone. Because when I look at you in that flavor, I also now see when you drop off in those hormone states, because that makes a big difference in how the pain gets expressed. Both are anti-inflammatory, your sex hormones. So we always need to take a multi-dimensional approach. That's why the one needle, one medication, it's just not enough. So we want to think about it this way. In your community of care, some may be medical, like the Blue Circle. Some may be allied health, our physios, counselors, acupuncturists, traditional Chinese, medicine, the works. And then, of course, everything around health literacy. And today is one of those days. We've gained a little bit more knowledge around the pain channels. We're gaining more knowledge around maybe where we can get help. Just an example at our clinic, how we try to do this is blending medical, our allied teams, because we want to be able to talk to each other. Why is this person not able to move, maybe balance? Maybe it's this muscle. Maybe we can do something at a medical level. But that's why, just like Shirvin mentioned, Pain BC, Pain Canada, we also have group medical visits that are very specific to these many, many conditions that we talked about earlier. Here's how you want to think about it. Traditionally, you will have your doctor appointment. So these are your blue lines. You'll have a consultation, some assessment, some idea of the direction. Hopefully, you're also gaining knowledge along the way, because I have to tell you, the neuroscience is powerful. Example. Just that breath alone is something that triggers off the vagus nerve system. That rebalances that stress system that we talked about, and just that alone reduces adrenaline, cortisol that's secreted by your adrenal glands back here. When you reduce that, you reduce insulin resistance, you reduce inflammation, you reduce the contraction of your blood vessels. You can go on and on. Just breath alone. When we do this, no needle, no medication can do that, the work that you must do. So that's why this neuroscience is critical. And then, of course, our allied health team, because it's not just one person holding the knowledge of how your body works or isn't working. So let's talk about the role of interventions. Our clinic looks like this, but many pain clinics will have a variety of these kinds of resources. Ultrasound guided procedures, maybe x-ray related procedures as you see with this C-arm. This bay here we call forest wing, because we do numerous different types of therapies, including advanced infusion therapies, ketamine assisted psychotherapy. So you're just hearing these terms. I'm using our clinic, but many clinics that are listed in Pain BC will have a variety of resources. I wanted to focus up, it's a little bit maybe not so visible, but I'll read it. That's why the layer 1 of the pyramid is all around your neuroscience, understanding pain science, stress management, nutrition, sleep hygiene, mood. Seems pretty basic, but many people, for example, even when I was an anesthesiologist, I never got my 7 hours of sleep, and I thought I could get away with it. I can't. Because it hurts our brain. And therefore, these basic things, when we're trying to repair the body, we are needing to address that. So if someone comes in and sees me for back pain, but if we don't ask them about nutrition, mood, and their sleep, I'm missing the big picture on how their body repairs and reduces the inflammation. That needle doesn't do all of that work. The second layer, this is how I think about it. Like your skin, then you've got the fat underneath, you've got muscle layers, ligaments going down all the way to the joint. So when we think about, let's say back pain, migraine headache even abdominal pain, we think about it as in layers. We've had people where simple trigger point injections or intramuscular stimulation, massage, somatic therapy was just enough. I've treated headaches, treating calf tightness by treating headaches because I heard what that person told me. They wondered about a link. It sounded crazy to them, but I don't think that's crazy. You know how you feel inside. So we have to listen to that. And it may be that muscle layer. Then we might have to go a little deeper. For example, someone who's had back pain from a motor vehicle accident, 7 years. You can't just go into weight training and think, I'm gonna go strong. You just feel scared to pick up that weight, let alone go walking. So we have to build in the system. Safety is mentioned by Shirvin. We have to build in some help with professionals like our physiotherapists or trainers to showcase what is maybe disconnected after years of not walking. You might not be activating the core. So many different things. I used to think, I'll just exercise more. And I actually, through my bone scans, showed I kept losing muscle and bone because I was crossing into menopause. And I didn't understand that just doing the same thing I did 30 years ago doesn't work. So when I shifted things and I worked with my providers, it made all the difference, and I'm deadlifting 225 pounds. I know. I said the same thing. I said, really? And what I only cared about is I grew my bone. That's all I cared about. And that's what I care about all of you. When people walk into pain clinics now, if they're not asking the questions, I want you to ask those questions. How can I gain my strength? How can I move my bones so I can load them? And that's what's critical. So that's why these advanced layers. So let's talk practical now, right? So if you can't get the neuroscience education, there's online stuff through Pain BC. Welcome a new guest in. Hello, welcome. And so that's why please don't think just because you might not have something on the island. And I know this community center is amazing. There's such a nice wraparound team that's growing right now. You'll hear from one soon, Sandy, that even if you don't have that all on site here, online, don't hesitate. You'll notice here, we'll go everything from body-based problems. Then there's also even yoga, Pilates, active movement, everything, all covered by MSP. But you'll notice things like brain mastery, brain health, because they're critical for actual pain care. Here's some examples of what we could do. Not just our clinic, many pain clinics, but you'll need to ask. So if, for example, you don't know where to start, they should be at least starting with your muscles. Let's say for headaches, you've done the standard thing. Often you will have your basic medications. You might have done some Botox for headaches. You might have had transcranial or maybe osteopath acupuncture. If that's not working, don't give up. There may be nerves. There may be certain insertions of the neck muscles that are pressing on nerves. Maybe it's joints in the neck because of that whiplash from a few years ago. So don't give up. Meaning, think about this as layers. That's how we think about it. So if it's not working at this level, let's take a look at another level. I don't want you to have procedures forever. We just want enough that it builds you the confidence. It gives you this window of time where now you can build your body strength. That's the role of these pain procedures. There are these other things, for example, radiofrequency lesioning, cryoablation. These are now new therapies available to retrain, reshift the way nerves behave. Shirvin made a note. She had showed a video where it showed all these little extra stress receptors as growing when you were trying to protect the body from pain. It's very interesting when I have patients with widespread pain, people I can't even touch their skin. And what's happened a lot of times is not only a nerve sensitization, there is an emotional connection with the amygdala, so it's a real wind-up syndrome, right? It's like someone getting burned on their hand, everything's healed, the stove is off. If you put your hand there again, you'll feel the burn in your hand because this is an actual memory. There is now a linkage with your emotion and your memory, etc. So that unlinkage has nothing to do with the tissues anymore, right? So, but there are times in which you've got to get at the nerves. Examples are spine pain, neck pain, low back pain. We know some of us, we have degenerative disc disease, we have facets, the joints that spine vertebrae sit on. And sometimes we have back pain. These things are so stubborn. We have to take away some of that sensation. It doesn't cure the disease, but it will at least help you move. And when you start moving more, you build your muscles. When you build your muscles, like this knee, you start supporting the joint. And that's what shocked me. I never knew this. I never got taught this when I went through as a pain specialist, to actually build those ligaments differently. When that happened, even though these joints look degenerative, because there's thousands of studies showing that what's shown in the MRI, not equal to what you feel, not equal to how bad you move. It's not equal. So what's important right now is not relying on the MRI CT. They help guide our therapy, make sure there's no cancer, no fracture, infection, but they're not the thing to focus on. It's really around your function. What else can be done? So for joints, there's some really fancy things now. Please, everyone, if you can avoid, not have steroid injections in your joints or muscles. Listen, I was trained 20 plus years ago on that. That's what we knew to do. If the local anesthetic worked for you, let's say froze an area, froze your joint, and you felt relief, the next step there was a steroid injection. Because the steroid was cortisone, as you know by kind of normal terms. It's to reduce inflammation, and it does, but it only does it for 3 months. It's the same kind of steroid you secrete under stress. That's what we call cortisol. But when it's a drug, it's now an injectable medication that only lasts 3 months. The problem, it weakens muscles, weakens bones, if you use it too often. So a one-off here and there, it's okay, maybe to get you over something. But there are now better ways. We can use, for example, I have seen people where they said it was bone-on-bone arthritis. I've actually dealt with their nerves, and it was no longer arthritis in the knee. So we don't know it's actually in the joint. We need to go layer by layer. Is it your muscle? Is it your joint? Is it the way your nerves are processing the nerves? Is it the lack of muscle, like in my case? Is it that the tendons are getting a bit stiff because I started crossing menopause? So we gotta do layer by layer. And then you build in the movement layer by layer. The role of a pain specialist is to help with that kind of that sharpness that just gives you that fear not to go a little further. That's our role. If you're just getting them forever, the injections forever, that makes no sense either. Because that, like anything else that's being done to you, takes away the work that you do alone. Because there's nothing that replaces your immune system, your hormone system, your muscles, your bones. Nothing replaces that. Okay, so that's where we have to move towards. Here's some really fancy things, because I saw some hands up with neuropathic pain. So many times in the past, he said, you got to live with it, including widespread pain. You've got to live with it. That's not true. There are different subsets of people. Widespread pain can be, Shirvin made a note in a video, these glial cells. Okay? There are some housekeeping cells of the brain. 1/2, about 80 billion, are your neurons, like the nerve tissue, thinking nerve tissue. And then the other half, 80 billion cells, are these housekeeping immune cells. Think, wow, that's interesting. It's that much housekeeping in the brain. These glial cells are powerful, and that's why I often, if you have widespread, you have abdominal pain, you have, let's say, neuropathic, I will advise people a vitamin called palmitoylethanoamide, PEA. I will maybe pair that up with low-dose naltrexone. Maybe some of you might need to go in the direction of things like infusion therapy, because like ketamine-assisted psychotherapy, IV infusion for lidocaine and ketamine, they can dampen down the signals, because sometimes the body raises too many receptors. What feels or signaling 10 signals here is experienced as 1 million. So see, the radio signal is disconnected from the injury, and that's why instead of just treating this, we sometimes have to dampen down the radio signals. Okay, so I can't emphasize this enough. This is Canada data from our own osteoporosis societies. It just basically goes to show you here by the age of about 70, the red bars are women, the blue are men. So what's happening right now is that we start to see, at least our Canadian data, is that there's quite a significant, this larger bar starting here is just hitting 60. This one here is 50. So we can see right now, based on the way we normally do things in our normal culture, sitting too much, not being encouraged to weight train, maybe not starting hormone therapies early enough for men and women alike, we are starting to lose bone and muscle when we don't need to, and we can reverse that. Face. What is exercise? Weight training is any one of only C, capacity. We don't want to just walk. In my TEDx talk 3 weeks ago, I did emphasize walking and cardio are great for heart health, but they're often not enough to build muscle and bone. And we know that. Now we really know that. And so where we can, let us help you as a provider team. Find ways where we help you load your bones. When you load bones, which means they need muscles to pull on them, then you'll build bone. At the same time you build muscle. And at the same time you build this functionality with the ligaments. Because it's not enough just to do this. We want to do this. And we want to do this when we fall. That's where we're really going. It's not being fancy. It's not being exercise trendy and wellness. It has nothing to do with that. It has to do with the everyday, when I fall, my bones will withstand that. Because when we get that hip fracture, death is high. And if it's not death, it's long, long, poor recovery. We don't want that. So therefore, F-A-C-E. F is footwork. So as we now start to think about various ways of moving, see if you have no time, let's say very little time, let's really focus on at least that strength, resistance, even the push-up on the ground. Those are resistance, the wall sits. Wherever we can, we start there. But don't just stop there. Let's make sure that we build in footwork or spine work. We know why one reason why sitting is not great is because we're like this. One direction. If every day, even your yoga, your basic Tai Chi, your basic Qigong movement, all of this allows you 360-degree movement around the spine, super important. Why? The discs don't have blood vessels. They need you to milk the fluid around the discs. So for us to protect our spine, we need that movement. So that's another reason why just sitting still is hurting us. But that's not our fault. It's not your fault. It's the conveniences of our modern life that we just have to be mindful of to interrupt. That's what we want to be mindful of. Now, E, equilibrium. We do want, why not? At the grocery store, you're waiting around to buy your groceries. Why not just stand on one leg? You don't have to be fancy. You don't have to look like this. Although I encourage you, the more you do that, the more people will ask. But I swear to you, at first you might feel like this. But later, you don't need your foot. Later, you start to move. Later, you can just do multiple things. And it's incredible how quickly your mind connects to your muscles and bones. Because that's proprioception. So we already know, you don't use it, you lose it. That's it with everything. And same thing, that's another reason why sitting harms us, because we are not allowing the body to get these stimulus. And finally, the heart health, and I mentioned that already. So that's why we always like to support our allied health teams, the big key takeaways, and that's why I want to utilize the time with your stories. That's why I intentionally went into the key takeaways here. We know now, in BC, it's accessible. Getting that neuroscience is powerful, not just for your pain. Do it for brain health. Do it to get understanding, to prevent dementia. Okay, so I'm going to go into that shortly. Early intervention is critical. In the past, when I started back here after my Australia training, the wait lists were 5 years, 10 years. That's not early. And we're sitting around trying to get help. That doesn't help. We're now seeing a big difference with that. But this layered care approach is really critical. Because if your providers aren't thinking like that, which I understand, many don't, because they're not necessarily pain trained, like you see the folks who are speaking today, you have to think like that. You bring that to them. You drive those goals, right? And then it helps them focus. So these recovery concepts are not just for pain. It is really strength for life. And that's why I talk about strength means freedom. The ability to live life on our own terms. And even if there's injury, we can now, as that kind of putty example video, that doesn't mean we're back to where we were at 20 years old, but it does mean we can expand something very different. Anti-fragility means not to be weighed down by the stressor, but you really pivot to see your capability beyond what you have right now. Okay, so I'm going to end the formal part of the talk here. So thank you everyone for your vulnerability.
Thank you. Thank you very much.
So our final speaker is Sandy Logan. Next to me, Sandy is a physiotherapist on island. Has been providing care on the North Shore and Bowen Island since 1994. Sandy graduated from Queen's University with an honors degree in physiotherapy and an honors degree in kinesiology, also from Dalhousie University. She has a broad background in management of chronic pain conditions and the treatment of sports and orthopedic injuries, including my own. I credit Sandy with a new lease on life. Fixed my knee. I preach the gospel of Sandy. She's a strong advocate for holistic care, working with diligence and empathy to help determine the causes and effects of injuries. Through education and awareness, Sandy encourages her patients to play an active role in their treatment and challenges her patients to maintain a full and active lifestyle. So please welcome Sandy.
We recommend that you look at their websites. Pain BC is an amazing resource for everything chronic pain management. There are courses online. There are support groups online that you can join. They're an incredibly well-established program. I can speak from experience. I wished I'd had that toolbox 30 years ago when I started my own personal pain experience, because it's an absolutely phenomenal website. And I had an opportunity to take a peek at Dr. Brenda Lau's website. Again, I can't speak highly enough about it because there's so many useful resources available. Sort of cheat sheets in terms of the questions you should be asking your healthcare provider to provide a foundation of knowledge that you can take in about your symptoms and start to form partnerships with your clinicians so that you can work to move ahead with your pain journey. Okay? I had a speech. Now I'm making it up as I go along here, and I thought to kind of round it out a little bit, just very brief personal history. How I got involved in chronic pain is actually my own personal journey. 30 years ago, I had an autoimmune diagnosis. Autoimmune arthritic condition was diagnosed. My doctor told me, she sat me down one day, she said, you know what, this is a pretty serious condition. And she started pulling out the disability insurance papers, and she had a script in her hand. She was writing out a script for a motorized wheelchair for me, because she said within the next couple of years, because of this advanced state that you're in, you are going to be in a wheelchair, right? So, deer in the headlights, okay, shock at this diagnosis, number one, but the road ahead that was already assumed that I was going to be on. So what I thought about as I was thinking about this last night, I said, okay, what have I learned both as a patient but also as a clinician over the last 34 years of practice that I thought that might be useful to pass on to you, and then we can have a little bit of a conversation around that. So the first thing I learned from that experience is language. How important language is when you're talking about a diagnosis of a significant condition, whether it be an illness or post-operative injury or physical injury, emotional injury. The language that you use when you're communicating with your clinicians, with your family members, with your colleagues, it's critically important because the words, they themselves can really drag you down in terms of how you deal with your personal situation and how you interact. So getting better at it, we're learning all the time in terms of how, as clinicians, we provide information, we provide education about different things that are going on with a person in crisis. So we're still learning about that, but I really encourage you to think about the language that you communicate with, but also think about the language that you use with yourself when you're talking to yourself about your situation, how you're feeling, okay? Treat yourself with empathy and curiosity, okay? Ask questions of yourself because this is the best diagnostician, not the diagnostician, but also the best healer is what you have inside, okay? Where we become helpful as clinicians is how you access the best healer that you have available to you, and that involves very many forms, so we'll talk about that in a minute. So that was the first thing that I've learned is the language, like how I use the language to communicate with my patients, but as a client myself, okay, when I'm talking, I learn what questions to ask, what's valuable information to get my story across to whoever I'm talking to. I learned how to listen better as a clinician, but also as a patient, listening to my own body signals, learning to approach my pain signal with curiosity rather than fear, rather than avoidance, rather than suppression. I approach it with curiosity and say, okay, what's going on here right now in this moment? What's happening? I approach that the same way in my clinic visits with my clients. I say, well, how are you feeling today? What's going on in your body? And I'm not just talking about a physical part. I'm talking about the whole system. How's your sleep? How's your energy level? How's your mood? How's your nutrition? All the things that we've been talking about today. So learn to listen to yourself. And I invite you to do that just for a moment here. We'll do this as an example. Just close your eyes for a second. And I just want you to sit quietly for a moment and just be with yourself, okay? No distractions, there's no phones. I'm going to be quiet here for a second. I just want you to be in your body for this moment. And now take a nice, slow, relaxed breath in and breathe it out. And then slowly come back up into the room. Okay? How many opportunities do we get in the day to do that? To slow down and be curious about what's going on in our body. Okay? We're so distracted by digital, work, family, everything that's going on. We forget that we have this huge device called our bodies that's crying out for attention, but we just don't pay it enough attention. So I invite you to ask questions, to take the time out of your day to sit quietly and ask your body, how you doing? Okay, what do you need right now? What do you want? What do you want to not do for a while? Okay, you want to shut that phone off and go for a walk. Okay, ask yourself these questions and you'll be surprised at how much more information you can get that gives you guidance in your next steps of how you approach your journey. Okay, so that's something to think about. So, language, I learned to listen. I learned that I wasn't alone, okay? 30 years ago, I so wish I had these toolboxes that Shirvin and Brenda have given us today. 40 years ago, when I was in school learning about chronic pain, it was just a definition in a textbook. That was all we had to go on. Pain that lasted longer than 3 months. Boom. That was pretty much all we had. Fast forward now 40 years, huge explosion in research, in dealing and managing chronic pain, and we're still learning. We don't have all the answers, but just know that we're not alone, that there's so much support now available to access. It's just, you start asking questions, you start researching, okay? You know that there's resources available. And if one door is closed, you keep looking. You don't stop looking, okay, with that, because there is the help available, okay, with that. So what's the other strategy that I learned? Go back to my cheat sheet here, okay. What the other thing I've learned, both as a patient and as a clinician, is that change takes time. Okay, I hear this all the time in a clinic. I said, well, I did the exercises for a couple of days. They didn't work, so I gave them up. So there, okay, they didn't work. Change takes time. And you do it slowly, you do it progressively, incrementally. You check in all the time with how changes are impacting your body, okay? It takes time, it takes consistency, it takes practice, okay? And guess what? It changes as well. Your needs change over the course of your condition, okay? Your team changes over the course of your condition. Maybe physio isn't appropriate. Maybe it might be massage therapy or traditional Chinese medicine for a while. Your needs change over the course of your journey, and it's important to keep checking in with yourself to see what feels right at that moment in time to be accessing, okay? So that's the other thing that I've learned. When we put it all together from all of that information that we've gathered, know that here on Ireland we have a tremendous volume of knowledge. We have a tremendous sort of support system available to you to help facilitate the journey that you're on. There's some amazing physios at Integrated Health. There's occupational therapists. There are amazing registered massage therapists, traditional Chinese medicine practitioners, personal trainers, counselors, psychiatrists, psychologists. We have a huge number of individuals on the island that are available for access to get help. And if we don't have the answers, we research and we refer, right? We look elsewhere for help as you go forward then, okay? Just to kind of give a little final plug, we just started with Dr. Matt Blackwood, he's just left, a program at the rec center called Fit Guys. And I don't know if you've heard of the program in West Vancouver. It's based on a process that they have called Fit Fellas. And it was an exercise group that met every day or twice a week for our case for exercise, cardiovascular, strength training, flexibility training. But the fourth pillar of that was social. Okay, we get together after the class and we have social time. We're hitting all of the 4 pillars of health, which is the mental, the physical, the spiritual, and social, okay, with that. So know that, and that's just one example, know that there are many examples of classes that you can join, groups that you can access for support, and just know that you're not alone in this journey, okay, with that. That's all I'm going to say now because I know there's questions that they have for our speakers here today. But thank you all for coming out.
Thank
okay.
you.
Yeah.